So let's continue for the part 3 of physiology MRCS from this. This is the important topic, hemostasis and coagulation. Hemostasis is control of bleeding and coagulation is clotting of the blood. Cessation of bleeding, physiological hemostasis consists of series of complex. So there are complex events that happen to control bleeding whenever there is trauma, injury and everything. This involves endothelial cells. Endothelial means internal cells of the lining of the vessels or anything. Second is important platelet and clotting cascade, then fibrinolysis. These are the series of events that occurs. Key events in hemostasis: vascular injury, the first thing, exposed subendothelial tissue factor. This is subendothelial tissue factor and collagen. This exposure of this to the tissue that immediately leads to vasoconstriction. Platelets adhere and aggregate at the site of injury, forming platelet plug. Activation of coagulation cascade, then platelets stabilize the plug, that is by formation of fibrin, and fibrin is cross-linked. Then after this is clotting. Here till you have controlled the bleeding. Now body has natural mechanism to break down this clot, that is called as fibrinolysis and vasodilatation, the regulatory. So step by step these things occur. What are role of endothelial cells? Endothelium, any of the vessels which are inner lining is called endothelium. Endothelial cells form the barrier between their enveloping connective tissue and the blood. They also produce thrombotic. They cause thrombosis and antithrombotic. Both the factors are there. What are antithrombotic factor? Which is preventing the thrombosis, because blood is flowing inside the vessels that should not be thrombosed in a natural way. So it has got antithrombotic factor, which are called as prostacyclins, prostaglandin I2, thrombomodulin, nitric oxide, tissue plasmogen activator. These are antithrombotic factors. What does platelocyclin do? Prostacyclin prevents platelets to get adhered, aggregation. Otherwise in the blood there can be naturally aggregation, and that may cause lot of clots inside the vessels. So that prostacyclin is a vasodilator as well as prevention of platelet. So it is anti-platelet, prevents aggregation. Thrombomodulin, a glycoprotein bound to endothelial cell on complexing with the thrombin. This is the thrombin. It complexes with thrombin and activates protein C, cofactor of protein S, which degrades factors 5 and 8A, reduces fibrin formation. This is the question. This is the natural mechanism through protein C. It acts on 5 and 8. Just try to remember this question. Thrombomodulin activates complexing with thrombin to activate protein C, which degrades factor 5 and A and reduces fibrin formation. Nitric oxide is cause various mechanisms cause vasodilatation and inhibitor of platelet aggregation. Fibrinolysis. This is fibrinolysis. Once fibrin clot is formed, fibrin clot, it is broken down into fibrin degradation products. So this is called the fibrinolysis. Fibrinogen is acting here. So fibrinogen is converted to fibrin, and this prevention of this. That is the. Now this is about antithrombotic. What are the thrombotic? The factors that causes thrombosis. These are von Willebrand factors, platelet activating factor. This is platelet plasmogen activator inhibitor. Now you see TPA, tissue plasminogen. So this is plasminogen activator, which breaks the fibrin into small breakdown of the fibrin. So that is activator. This activator is inhibited by ATPA. This is the inhibitor. So if this is inhibited, clots cannot be broken down. The fibrinolysis cannot happen. That is the thrombotic factors. Von Willebrand is the factor 8, factor 9, cofactor for platelet adhesion. It causes platelet adhesion. So it is preventing, it is causing, this von Willebrand causes platelet adhesion with the factor 8 to form platelets, clots. So platelet activating factor, PAF, aggregation. So this thrombosis is totally opposite to antithrombosis. What is the role of platelet in hemostasis? This is the most important crucial layer is platelet hemostasis. At the site of vascular Von Willebrand factor, factor 9, they bind via wall Willebrand factor to subendothelial collagen. So platelet adhesion, it helps for platelet adhesion along with the factor 8. On activation, they secrete the content of alpha granules and dense alpha and dense granules. So alpha and dense fibrinogen and ADP induces aggregation and thromboxane causes vasoconstriction. So thromboxane A2 vasoconstriction, fibrinogen causes aggregation. These are from the alpha granules. Aggregation of platelet forms the platelet plug. Their cell membrane becomes pro-coagulant by providing binding site for collection factors and fibrin. The platelet plug becomes stabilized with the cross-linked fibrin. This is the way platelet plates. Now clotting cascade, there is one antithrombin 3 which inactivates thrombin in presence of heparin. So heparin acts through antithrombin 3 which is activated leading to inactivation of thrombin. It also inactivates factor 7, factor 9, 10A. So 7, 9, 10, 11 and even some say 12, 9, 10, 11, 12. So this is clotting cascade, antithrombin. Fibrinolysis occurs in response to vascular injury. Plasminogen is converted to series of protein plasmin by number of bacterial plasmin not only cleaves fibrin. So fibrin is formed final product which is the clot. So plasminogen is activated to plasminogen to plasmin. Plasmin acts on fibrin to break it into the disorders of hemostasis. The relationship between thrombosis and this is thrombosis at one side and fibrinolysis is finally balanced. The disorder results from the disruption of equilibrium with overemphasis on deficiency in one system relating to other. Results in. So what are the predisposition to thrombosis? Common bleeding disorders are predisposition to thrombosis, thromboembolic disorders in. So this is intrinsic and extrinsic pathway. Intrinsic pathway starts from factor 12 to 11, 9, then 11 to 11A, 10, 9 to 9, then finally there is 10th. This is the common pathway. Extrinsic pathway is by the tissue factor, and this is surfactant precalcitonin. This is the subendothelial. So here factor 10 is activated to factor 10A, which stimulates this is prothrombin to form thrombin. So prothrombin is factor 2, it is converted to thrombin, and activated thrombin acts on fibrinogen to convert it to fibrin. Now then fibrin is broken down, first cross-linked to form fibrin, insoluble. This is. Then what happens? This is coagulation system and this is fibrinolysis system. Second part is fibrinolysis. What happened? The fibrin is product degraded into fibrin degradation products by the activation of plasminogen to plasmin. This is called as by tissue plasminogen activator is the major factor. So streptokinase, urokinase, these are called as, these are breaking the clots, fibrin. So thrombolysis, this is called as thrombolysis. Once clot is formed and it has to be broken down. So streptokinase, urokinase, factor 7A, kallikrein, these are used. Fibrinolyzed tissue release from the screening blood test. What test you do? Full blood count and film. Thrombocytopenia is most important. You have to need platelet count has to be measured. Platelet dysfunction specific assay. APTT. Now this is first one is a longer pathway. So APTT. Here the main action is from the heparin, and this is intrinsic factor. This is prothrombin time. Here the main action is by warfarin. Warfarin active in 1972, 10, 9, 7, 2. So you can measure the factors here. 7 is important factor here, and 9 is also here. Then 2 factor is again prothrombin is 2, and 10 is the common. So these factors are for, this is for the warfarin prothrombin time. Prothrombin assesses the extrinsic mechanism, factor 7, as well as common pathway. It often expresses INR. So this is expressed as prothrombin time is INR. So whenever warfarin is given, you monitor INR. The ratio has to be 2 to 3. Whenever heparin is given, either unfractionated and low molecular doesn't require monitoring, but unfractionated heparin, long doses heparin, you measure APTT. That has to be again by normal tissue is 30 to 40 seconds. APTT is measured as 30 to 40 seconds APTT. Prothrombin time. Thrombin time, this defect detects the deficiencies of fibrinogen or inhibitor of thrombin. Thrombin time, just what you have seen, the thrombin is prothrombin to thrombin. This is the last. Here is the TT, thrombin time. It detects the deficiency of fibrinogen or inhibition of thrombin. Normal time is 14 to 16 seconds. This is just 14 to 16 seconds. So thrombin is stimulating fibrinogen to fibrins. It should be very fast. Specific coagulation text as a genetic disorders. For that, you measure hemophilia, that is factor 8. So these are the screening tests for hemophilia, factor 8 deficiency. It is also called as hemophilia A, and factor 9 deficiency. 9 is also called as Wall-Wilbrand disease. So Wall-Wilbrand disease, fibrinogen, and to detect the fibrinogen, fibrin depletion product useful for detection of ongoing intravascular coagulation. So results of blood test in common in bleeding disorders. These are So what are the results of blood test in common bleeding disorders? See, this table actually it is not confusing. We have to understand what is the, whenever there is liver disease, prothrombin time, activated partial thrombin time, and this is thrombin time and platelet. Platelets are decreased. Platelet count has to decrease whenever liver disease is there. And prothrombin time APTTs. PT is basically for the extrinsic pathway and APTT is for the intrinsic pathway. And thrombin time is just conversion of thrombin to prothrombin to thrombin and then fibrinogen to fibrin. That is the last part which you have read. Deficiency of fibrinogen or inhibition of thrombin. Normal is 14 to 16 seconds. It is normally 14 to 16 seconds. And APTT is 30 to 40 seconds. And prothrombin time is normally measured as INR. It should be within 2 to 3 whenever you are giving. So prothrombin time is basically, PT is for extrinsic system. This is for extrinsic pathway. APTT is for intrinsic pathway. And thrombin time is final conversion of thrombin to prothrombin to thrombin, and thrombin activated thrombin convert fibrinogen to fibrin. So it is last two steps. And platelet, okay. So whenever you are giving warfarin, so warfarin is basically acting on extrinsic pathway. So that's why warfarin is acting on factor 1972. So this is 10972. So major are 1072. 2 is prothrombin converted to thrombin that activates fibrinogen to fibrin. So this is the last stage. 7 is the start of extrinsic pathway, and 3 is the factor which activate tissue thromboplastin. Then 10 is the common pathway, and 9 is platelet is moved to form the platelet. It is start of the clotting. So platelet adherent is helped by the 9. So warfarin is acting through inhibition of vitamin K. That's why all these extrinsic pathway, prothrombin time PT is used for extrinsic pathway. So this is increased, and rest of the intrinsic pathway, APTT, thrombin time, and platelet count, all these are normal when you are just giving warfarin. So in contrast to this, when you give heparin is acting on the factors all the factors of intrinsic pathway. So it starts from activation. Heparin's action is on, we are just read here this 1970, 7, 9, 10, 11, 12. Thrombin presence of heparin. This is heparin activates antithrombin, which inactivates thrombin. It also inactivates factor 7, 9, 10, 11, kallikrein, plasmin. So 12 is the last plasminogen activator to plasmin, and there is, so 7, 9, 10, 11, 12. If you see heparin, it's acting on 7, 9, 11, 12 as well as 2 also, 2, 7, 9. So what happens, this is the heparin is of intrinsic pathway, so this is increased, it's acting as well as thrombin time, so it is activating through antithrombin, so this is also increased. So these two because of heparin. Factor 7 deficiency is directly for the extrinsic pathway, so it will be only this part is prothrombin time, PT is increasing, factor 7 deficiency. This is asked, this is hemophilia and VW, von Willebrand. For hemophilia, the mnemonic is HAT and this is VAB. APTT, this AT is for APTT. If you see factor 8 deficiency, hemophilia, only this is increased. And factor 9 deficiency, this is factor 1 Willebrand. This APTT as well as bleeding time is increased in this. Plus bleeding time, which is not given here. A is activated prothrombin time and B is bleeding time. What you see in DIC, all these are increased. This one is increased, this one is increased, this one is increased. All bleeding tendency and platelet count has gone down. So common bleeding disorders can be congenital, right from the birth, hemophilia A and B. Von Willebrand is factor 9. This is with factor 9. This is factor 8. So this may be Willebrand. Yes. Platelet function disorders. Acquired is thrombocytopenia, one is the platelet function disorders. Because of start of any antiplatelet medicines, aspirin, clopidogrel, there can be functioning disorders, vitamin K deficiency, or renal failure, acquired vascular defects. Congenital disorders, you see, hemophilia is X-linked. A is X-linked. It affects most commonly in the males, but female can be characterized by bleeding tissues, muscles, bleeding in the tissues, muscles, and weight-bearing joints. Sudden, delayed for several hours after injury. Functional factor 8 determines severity of disease, frequent bleeding after minor trauma, severe disease, moderate disease, less than 5%, less fluid, mild disease, persistent bleeding, usually secondary to trauma. Most affected individual factor levels develop antibodies against. There is antibodies against factor 8. Treatment depends on severity of disorders. Factor 8 concentrated has to be given. Now hemophilia B is also called as Christmas disease. B is called as Christmas disease. X-linked clinically indistinguishable from A. It is usually 1 in 1 lakh male birth. Defect in deficiency factor. Here is factor 9. Either prothrombin complex concentrate and contain vitamin K. Wall Willebrand factors is common occurring as a plasma glycoprotein, has two main functions at the sites of what happens. Wall Willebrand is plasma glycoprotein that has two main functions. It causes platelet adhesion, subneural site of injury, and it serves as plasma carrier for factor 8. The main disease subtype have been described. Type 1 most common, autosomal dominant. and variability inherited. Type 3 is autosomal recessive. Mucosal bleeding is there, petechiae is there, epistaxis is there, similar to platelet blood disorder. Treatment depends on symptoms, underlying causes. Cryoprecipitate is the main treatment. Congenital platelet function disorders, they be burnout solid syndrome, defect in platelet membranes, gray platelet syndrome, defect in storage granules, and cyclogenous thrombosynthesis. So acquired whenever platelet count is going down, that is acquired 150, spontaneous bleeding occurs at 240, spontaneous very severe if less than 20. Causes includes decreased production, marrow aplasia, infiltration, uremia, ITP or DIC. These are the platelet function disorder. This may be non-steroidal anti-inflammatory drugs, heparin, alcohol, this vitamin K deficiency, soluble fat soluble vitamin, absorbed in small intestine. This is stored in the liver. It's a cofactor for production of factor 2, 7, 9, 10. And CNS. 30 days storage is there, but acutely ill patient may deficient 72 days. Vitamin K deficiencies are malabsorption, boil salts, hepatocellular disease, parental vitamin K in correction in with clotting within 8 to 10 hours. Fresh frozen plasma may be administered when there is ongoing bleeding. Hepatic diseases often accompany impaired homeostasis. This is because of decreased synthesis of coagulation factors except factor 8. So this is the question. Factor 8 is not lost. Decreased synthesis of coagulation. C and S is decreased. Antithrombin 3. Reduced activation of coagulation factors. Malabsorption. Renal failure causes platelet aggregation and adhesions. Acquired vascular defect. This is group of condition characterized by bruising after minor trauma. Senile purpura. This is senile purpura due to atrophy of perivascular supporting tissues. Scurvy is vitamin C deficiency. Steroid purpura, Henan-Sholon purpura. Ehlers-Danlos, collagen abnormalities. Thromboembolic disorders. Now there is thrombosis as well as embolism. Congenital prothrombotic disorders includes factor 5 laden mutation, antithrombin 3 deficiency, factor C and CES deficiency. Acquired disorders are DIC, viscosity, thrombocytosis, predisposing to thrombosis, increased viscosity, pulmonary embolism. Thrombophilia is the atypical disorder. Patients are often young, family history of thrombosis and condition of DVT. Thrombophilia. What is the investigation you are doing? Test to disorder includes factor 5 laden mutation, antithrombin 3, C and S. These are the screen. Identifying the genetic predisposition to thrombophilia should prompt screening of the family members. Avoiding use of oral contraceptive pills. Risk of thrombosis. Congenital thrombotic disorder factor 5 laden. A genetic mutation factor 5 gene causes V protein, making it resistant to inactivation C. Inactivated factor C at lower rate, leading to thrombotic state by increasing factor 5 in the blood. Common northern European population. Antithrombin 3 deficiency. This is how is the action of antithrombin 3. Rare autosomal disorders. Antithrombin inactivates thrombin factors 7. This is 7, 9, 10, 11. Antithrombin 3 level is measured by immunologic assay for deficiency in the with liver disease, DIC, nephrotic syndrome, heparin therapy. Protein C autosomal dominant. Again, this is penetrance, vitamin deficiency, glycoprotein, endothelial cell membrane causes reduction in fibrin formation. Acquired prothrombic disorders, disseminated is acquired. Pathological underlying conditions are most of the patients with easy bruising and may have produced mucous membranes and shock. Condition associated with DIC, malignancy, tissue trauma and obstetric complications, placental abruptio placenta, septic abortions, infections, gram-negative bacteria, miscellaneous. What are the laboratory findings? There is less platelets, all the PT, APTT, TT, all are increased. Fibrin degradation products will be seen. Management of DIC, diagnosis treatment, shock, exacerbate DIC, so acquired fluid resuscitation is the first line. Fresh frozen plasma, cryoprecipitate, platelet concentrate has to be given. Use of heparin is controversial. It is given in exam to reduce thrombin formation. Etiology of thrombosis. How venous thromboembolism occurs. In a response to factors, this is called virtuous triad. There is endothelial damage. There is virtuous triad. There is endothelial damage because of smoking, previous DVT or something. Smoking is the main factor causing endothelial damage, and venous flow or venous return. This is venous stasis. This is stasis. obstruction to the flow. Hypercoagulability means increased coagulability. Smoking again leads to hypercoagulability. Clots usually start in the deep veins and around the cusp, and usually in larger vessels following direct venous trauma. Dissolve spontaneously with or without treatment, propagate proximally. DVT occurs in 50% patients undergoing major abdominal pelvic surgeries. If no prophylaxis is given, it is common in the joint replacement surgeries in elderly people. 20% DVT risk of developing pulmonembolism. So out of this, 20% has risk of below the knee DVT is very small. It is essentially clot extent to above knee risk of deep vein thrombosis is common surgical patient problem which carries a high mortality and therefore should be prevented. It is usually post-phlebitic slim. Factors predisposing DVT are divided into patient factors. There can be patient factors, they are involved in disease factors and procedures. A relative risk factor of thromboplastin is normal. Relative OCP use, the factor increase by 4, factor 5 laden heterozygous, factor 5 laden homozygous, 80% increase in chances. Prothrombin gene mutation. Prothrombin gene mutation hetero and homo. Homo is again higher. Factor C, hetero is less and severe homo. Factor C, factor S, homo has got severity. Antithrombin 3 deficiency, homocystinuria. So age is patient factors. These are the congenital factors. These are the age, previous DVT, immobility, obesity, pregnancy, thermophilia. C and S, lupus, anticoagulant factor line, oral contraceptive pills. Factors involving disease or surgical procedures: trauma, pelvis, lower limb, congestive heart failure, polycythemia, inflammatory bowel disease, nephrotic syndrome, length of operation, risk of developing thrombosis according to the procedure. Now, what is the procedure? Less than 30 minutes, minor surgery, low risk, no risk factor other than age with major risk, more than 30 minutes. Age less than 40, less risk. Moderate risk is major urological, gynecological, cardiovascular, major medical illness, heart and lung disease. High risk fractures, major orthopedic surgery, pelvic surgery, abdominal surgery, lower limb surgery. Incidence of DVT after common surgical procedures without prophylaxis. If you do prophylaxis, then incidence of DVT in knee surgery is very high. Hip surgery increases. Elective hip surgery, prostatectomy increases. General abdominal surgery is also high. Gynecological surgery is high. So symptoms of DVT may be asymptomatic and difficult to diagnose. You may have high level of suspicion patient. Below knee symptoms, there is swelling in the calf, pain, calf tenderness is there, inflammation around the thrombus may demonstrate Homan's sign. Increased pain on dorsiflexion of the foot, that is called as Homan's sign. Calf erythema and scribbling mild pyrexia. Above knee symptoms may be difficult to diagnose. You may have high level of suspicion, scribbling pain, phlegma. This is phlegma cerula dolens, painful, edema, swelling, iliofemoral DVT. Investigation of DVT, duplex ultrasound is the investigation. Venography is the gold standard. Fibrinogen scanning is under research. Now lymphedema, differential diagnosis, lymphedema, cellulitis, rupture, Baker's. Wells criteria. This is again important. What is this Wells criteria used to determine probability of spontaneous DVT? Is a meta-analysis. Each clinical sign is assigned 1 point. Active cancer, if the patient is a cancer, treatment within 6 months, this is 1 point. Paralysis per se, recent DVT, 1 point. Recent bedridden for more than 3 days, 1 point. Major surgery, 4 days. Localized calf tenderness, 1 point. Entire leg swelling is 1 point. Calf swelling more than 3 centimeters rather than other limb. Pitting edema, collateral defect. So overall score, high probability DVT if score is more than 3, moderate 1 to 3, low probability less than 1. Outcomes is pulmonary embolism, it may lead to post-phlebitic limb resolution without complication. The highest risk of thromboembolism at the immediately after surgery. Measures are therefore required to prevent thromboembolism. What are the gentle preventive measures? Post-operative mobilization, early mobilization, adequate hydration, avoid cough pressure, stop oral contraceptive 6 weeks prior. These are the preventive measures, pre-operative you can. Specific measure against thromboembolism, graded elastic compression when fitting applied pre-surgery and left on until patient is mobile. So except in case of peripheral vascular ischemia, the intermittent pneumatic cuff compression, electric calf muscle stimulations, post-operative leg elevation and early embolation, heparin prophylaxis. This is very important. Traditional unfractioned heparin (UF) or 500 units subcutaneously given 2 to 4 hours before surgery and continued twice daily. Patient is mobile. This can be largely superseded by low molecular heparin. Various regimens are available. The advantage of LMR less longer half-life, only need once daily, lower incidence of heparin-induced thromboembolism. Heparin prophylaxis should be discontinued 24 hours before the administration or withdrawal of epidural anesthesia. Prevent bleeding into epidural space. Other agents affecting blood coagulability is antiplatelet. These are aspirin, dipyramidol, dextrons have been tried, although they do reduce platelet done in the widely used DVT. Oral anticoagulant not used for surgical DVT because unacceptable high risk of hemorrhage. In principle, method used to simple use is acceptable to the patients have been minimal adverse effect. All the hospital patients need to be assessed for clinical risk and risk of thromboembolism. Moderate high risk, which you have to do. So this was use of low molecular heparin 24 hours before it can be given. So symptoms and signs of pulmonary embolism depend upon size of emboli. Pulmonary embolism vary from multiple or small to solitary embolus, impacting the saddle embolus. Small emboli may be there asymptomatic. The pulmonary embolus, shortness of breath, increased respiratory rate, pleuritic type of chest pain, decreased oxygen saturation, sinus tachycardia, hemoptysis, shock, cardiac arrest. So these are the common clinical features: shortness of breath, respiratory rate, pleuritic chest pain, oxygen saturation, sinus tachycardia. Immediately ECG has to be done. What is the ECG? You see right strain pattern, right bundle branch block with Q3. Classical pattern of S1, Q3 and T3 is rarely seen. So T wave inversion in V3. Pulmonary embolism, T wave in V3. T wave inversion. Radiograph may show acute no changes. Checks X-ray no changes. Few days pulmonary infarcts. So arterial blood gas analysis, you can get type 1 respiratory failure in case of type 1 failure in ABG. Diagnosis is ventricular perfusion ratio not accurate in those pre-existing CT pulmonary angiography. CT pulmonary angiography is the gold standard. So complication of pulmonary embolism, treatment. So pulmonary have multiple emboli, cardiac arrest may be there, 10% hospital. Gradual treatment of DVT and pulmonary embolism. Gradual anticoagulation with heparin. Long-term anticoagulation is undertaken with heparin. Length of anticoagulation after surgery depend on the underlying cause of DVT and continued presence of risk factors in DVT. Cable factors, where there is a frequent, you have to put cable filter, then fumigating agent used very extensive DVT. So many surgical patients formally anticoagulation because of, in addition, some patients pathological defect in clotting and due to disease. So heparin is unfractioned heparin, warfarin, and antiplatelets. Anticoagulation, elective procedure. Some of the anticoagulation management depends on type of anticoagulation. For elective surgical, oral anticoagulant is balanced risk. So what is the antiplatelet agent? Aspirin is used, usually given prophylactic cerebrovascular disease. Low dose aspirin initially it acts by cyclooxygenase, affect platelet and therefore unable to synthesize thromboxane and become inactive throughout 7 days lifespan. So NACI reversible is again 3 to 4 days. Safe on the patient's perioperative, but certain disorders where special risk, thyroidectomy should be stopped. Dipyramidol use, it is to be used side effect. Clopidogrel, this has got must be stopped at least 1 week. Heparin is a potent anticoagulant. It is acts through antithrombin 3, thus reduces fibrin formation. Heparin utilized by IV protamine. This 1 mg protamine for every 1000 units. It can be given parenterally subcutaneously. Major INS APTT control plasma. Low molecular subcutaneously heparin, it may be stopped 24 hours before proposed date, and epidural anesthesia IV heparin may be prolonged. It can be discontinued. Heparin should be discontinued 6 hours before. Warfarin blocks the synthesis of vitamin K, elevate APTT, and it can be used because potential treatment consists of administration of vitamin K and fresh frozen plasma. INR ratio, it has to calculate between 1 or 2 to 3 actually given degree. Warfarin effects is monitored by 0.8 normal coagulation, 1.2 mild anticoagulation. So it should be this range. Normal therapeutic range is 2 to 3. Severe risk of surgical bleeding. Blood products are scarce and expensive, so blood components include red cell concentrate, platelet concentrate, granulocyte, fresh plasma. Use of blood products, blood coagulation, grouping, and cross matching. In UK, supply of the blood is based on the goodwill of the voluntary health donors. 90% of the donor blood is separated into various constituent. Blood grouping is done by ABO blood grouping. You can see here A, B, A, What is present an antigen on the cells? A has got A antigen, B has got B antigen, A, B, and B, no. So antibody in the plasma is B. In A there is B, and in AB there is no antibody. Transfer expression. So universal donor is O, universal recipient is AB. RH is RH negative. RH antigen is on the red cells. RH negative antibody is on the 85% patient blood incompatibility. So donor ABO, subsequent donors, antibody screening, cross matching is done, administration safety, ordering the blood products. When blood arrives in the ward, what to do? So you have to order with the name blood. You have to identify hospital platelets, check APO recess grouping, double check you are comfortable with this. Sharp spike of temperature. When blood transfusion, you may get febrile reaction within. So what to do? Transfusing blood, monitor temperature and pulse every 30 minutes. Sharp rise more than start intravascular coagulation, intravascular hemolysis, and the blood transfusion should be stopped. Slow elevation of temperature may be due to antibodies, and again white cell transfusion should be slowed. If there is any evidence of severe transfusion reaction, stop the transfusions immediately, recheck the patient identity, unit of the blood, blood bank, fresh sample taken, comparison. Use of blood products. What are the components? These can be RBC, platelets, granulocytes, and plasma is fresh fluorescent plasma. Fraction coagulation factor, it contains hemoglobins, albumin, and cryoprecipitates. Red blood concentrates in whole blood granules, platelets lose the function, mini coagulation factor loss the activity aggregation. So RBC constrained packed cells consist of the whole blood from the plasma has been removed. RBC suspension solution called as SAGM containing sodium chloride and mannitol. The volume of 1 unit is 350 ml. Shelf life is 35 days. Storage includes increase in potassium. It increases potassium and phosphate, decrease in pH and microarray and dead cells, and loss clotting factors. So washed RBCs who can tolerate granules. Use of rare blood glue. Rare may be stored for 3 years. Transfusion RBC considered may occur when HBC is less than 8, and when transfusion may occur if less than 10. RBC considered should be simply used. Platelets suspended 5 days at the room temperature. Indication for platelet thrombocytopenia, significant hemorrhage, consumptive coagulopathy, perfusion transfusion. Granulocytes have got 24 hours shelf life. Prepared a single donor. Fresh frozen plasma, centrifugation of donors, whole blood, 6 hours of collection, fresh frozen, 36 degrees, shelf life is 12 months. It can be up to 36. So, indication of prophylaxis, fresh not in hypovolemia, it is anti-albumin solutions should not be used as general purpose of plasma volume expanders. It has no proven definite. Coagulation factors, cryoprecipitates, these are the autologous transfusion used in the blood means alternate time. Therefore, 3 methods of pre-deposits, hemodilution, intraoperative is contradiction most of blood site of infection because of infection. Adverse effects of blood classified time scale was early, late, repetitive immunological complications. Incompatible RBCs, acute hemolytic reactions, incompatible WBC, pyrexia, incompatible platelets, purpura, reaction to the platelets, anaphylaxis, transient lung injury, TRALI, late complications, delayed hypersensitivity reaction, citrate toxicity, acidosis, hypokalemia, hyperkalemia, hypocalcemia, hypothermia. So early complications may be incompatible. Most of the ABO incompatibility, most common cause of death is ABO incompatibility. Immediate hemolytic reaction, most severe hemolytic reaction. 10 ml of the blood is sufficient to cause reaction. Rigors and substernal pain, restlessness, severe bleeding, hemoglobin, urea. Delayed reaction may occur within 5 to 7 days after the transfusion. Occurs approximately 1 in 5,000 reaction due to secondary response who have been immunized to the foreign agent by the previous reaction, but test therefore transfusion do not detect any antigen. This early reaction is antigen ABO incompatibility. The signs are minimal, unexplained pyrexia, fever, and hemoglobin urea. Management is slow spherocytosis and regular diagram anti-globin test. Direct Coombs test is performed. Check the liver function test. Incompatible white cells may lead to febrile reactions. Incompatible platelets lead to platelet antigen. Secondary response. Adverse reaction to the plasma may occur because of urticaria. TRALI is picture is ARDS, can occur in 30 minutes, several days after transfusion. Late complication is Infections may be because of hepatitis B and C. Can cause aplastic incidences, Yersinia, all this, screening of the donation, anti-C and anti-B include B transmission is 1 in 20,000 units and in 1 in 200,000, 1 in 150,000. Anti-HIV and all this. Complication associated with massive transfusion defined as blood fluid, it can result in cardiac abnormalities, ARDS, cardiac cytotoxicity may occur, acidosis may occur, hypocalcemia, hyperkalemia, hypothermia, clotting abnormalities, complication associated with repeated transfusions, miscellaneous complication of blood transfusion, fluid overload, air embolism. So this was about the blood transfusion.